Okay, welcome to today's program. My co-moderator is Duk-Woo Park. We all know him. He's one of the key person to TCTAP 21 virtual. The panelists are also well known and good friends. Luca, Testa, Yohei, Jung-Min from California, very early on, Ho-Jin Kim and Euihong. We're looking for two interesting cases. TAVR cases, and maybe Duk-Woo, you can present the cases.
Okay, thank you. I'm gonna present the pre-recorded case, and during the live cast demonstration, we will have discussion time in middle time and end of the live cast demonstration. I'm gonna start our live demo.
Thank you, everyone. Thank you, ladies and gentlemen, and appreciate participating TCT 2021 virtual meeting. We are very happy to introduce our routine practice of the TAVR procedure. And before starting our first live case, the TAVR demonstration, we're gonna introduce our team, and Dr. Go, and he is the senior fellow, and Dr. Bach, he's our junior staff, and we will start this case. This case is a very complex clinical situation. There are many portions we should do right decision making for this patient. Okay, Dr. Go, yes. Can you start the patient presentation?
Yes, thank you. This patient is 78 years old and was admitted for evaluation for the non-small cell carcinoma, lung cancer. In pre-op workup, and the echo finding shows severe degenerative aortic stenosis with normal systolic function. So this patient incidentally found out aortic stenosis during workup for lung cancer. And next, the risk factor for this patient is hypertension, and the STS score is quite low, 1.746%, and belonging to the low risk profile. And exertional dyspnea is a clinical presentation, NYHA function 2. And next. Echo finding shows the LV function was well preserved, 67%, and the Vmax is elevated up to 4.6, and mean pressure gradient is also elevated up to 49. And aortic valve area is 0.83. And next. So this is a CT finding of this patient, and this is the annulus plane. Annular short diameter is 22.1, and the long diameter is 27.1. Annulus area is 459 millimeter square, and the annulus perimeter is 76.7. And next, this is the sinus valsalva and the SC junction. What we focus on this slide is annulus sinus ratio between the sinus valsalva and the annulus. The ratio in sinus of valsalva is 2.3. And the mean ratio of the sinus between sinus and annulus is written below the table. The mean value is 1.86. So this patient sinus valsalva is relatively larger than the average, and in ST junction as well, the ST junction annulus area ratio is 1.41, a relatively smaller ST junction. So meaning that this patient have a very low risk for coronary obstruction. And next. This is LVOT, no calcified. And next, we always quantify the calcification amount, and in this patient, total amount of calcification is 177. Mean amount of total calcium of the cases, what we have done so far is around 331. So this patient have a relatively small amount of calcification. Next, this is a longitudinal analysis of the calcification. Distribution is not extended to the LVOT. A small amount of MAC is observed. And next, coronary height is more than 12, so quite high enough. And next, peripheral is also vessel size quite large enough for the transfemoral approach. And next, so this is a sizing table for the Sapien 3. Usual target oversizing in our center in Sapien 3 is 110% to 115% oversizing. According to the target oversizing, 26 nominal size is 113% oversizing, so should be optimal for this case. And next. Next. Yes, this is the case presentation.
Okay, great. So, and if I'm gonna introduce our Asan medical team about the TAVR procedure, and our team is reading and the team in South Korea, and we usually do annually 200 cases, and
Yes.
we almost do the 1,000 case of TAVR procedure. And if I'm summarize our routine practice, we usually more than 95% do the MEC, is a monitored
Yes.
anesthetic care with specialized anesthetic physiologist full support, and just the high risk patient, the 5% patient, we sometimes do general anesthesia. So, and if I'm going to summarize this patient, there are some risk factors, and
Yes.
you have a similar case, and this patient is lung cancer T2N0M0, and the pre-OP workup shows the
Yes.
very severe aortic stenosis. So, for reduction of operative risk, usually lung cancer requiring the general anesthesia. So, such like a very severe aortic stenosis is definitely imposed a very high the surgical list, and we should do something for this patient. Also, and one of the interesting and usually we do the CT based sizing algorithm, and for Eberhard system we use perimeter sizing. The Sapien system we use the area sizing, and usually we targeting 10% oversizing up to 15% oversizing. The key factor was calcium. The calcium is high or bicuspid valve. We do the lower sizing, the 5%, the 0% sizing. Also, and this patient shows the pre-TAVR CT scanning shows just a mild stenosis.
Yes.
But we checked the coronary angiogram. There is some different finding. Could you show us the coronary angio? 네. Okay, Dr. Go. Okay. Can you explain?
Yes, this patient had a history of the PCI, proximal PCI, a couple of years ago, and quite patent on the left coronary system. This is the cranial view. Center is quite patent and no disease. And left main is also clear. However, on the right coronary artery, we see the very tight lesion at the middle of RCA.
We check the final coronary angiography over here.
Ready?
Okay, angio ready. Okay, great.
Okay, so and we will have the discussion time at this point, and we present this patient is the background, history, as well as the current status. We will introduce the pattern of the TAVR, the step. And any question, comment, and Eberhard, could you introduce?
Yeah, I think that's an interesting case given the previous history of lung cancer. What I would probably do the same thing that you've done. I use looking at the coronaries and see to minimize everything that's around it, and then proceed with the TAVR, because that's what's actually made the projected surgery possible. The other thing that you might consider if you don't do TAVR, I know that some centers will do balloon valvuloplasty only in order to bridge to a later stage. But given the success of TAVR, particularly in your center with your experience, I think this is a very reasonable approach. Same session stenting of the right coronary. It seems to be not a high-risk PCR. So a PCI, so I think that's a very reasonable approach. Also, the sizing with 26 is a good one for the Sapien 3, minimal to moderate calcium, so that shouldn't be any problem.
Yeah, if I can, Eberhard, I must say that I totally agree with this process of tackling this case. I just want to say that in some circumstances, that would be great to have a CT scan that is also gated for the coronary arteries in order to save some contrast. I mean, our routine is to do the coronary angio only in those cases where the CT scan is unclear. But in particular, you may say that a CT scan nowadays in 2021 can be unclear when you have a lot of calcium. This is not the case, I guess. So the only comment that I can have is that everything looks absolutely fine in terms of findings, in terms of process, in terms of selection of the prosthesis. But ideally, we should be able to understand upfront. I mean, the idea is to save some contrast. So we should be able to know upfront if there is a coronary stenosis. But I understand that sometimes can be cumbersome. That's the only comment I have. Everything else looks great.
Yeah.
I totally agree with Luca's comment. We also take coronary CT angio for every patient. And my one specific comment for this case is that if he needs very urgent lung cancer operation, maybe I would skip PCI, because at least maybe 1 month we need to do antiplatelet therapy. So according to the only angio, the RCA stenosis is now not so tight. If the patient is not presenting acute coronary syndrome, I would skip coronary PCI and just doing TAVR and send to the lung thoracic surgeon without any antiplatelet therapy.
Yes. So I think that is a very good.
A very good point, Yohei.
Yeah, right. And so,
yeah, that's a very good point that you're mentioning, and certainly worth of discuss.
So, and usually, and sometimes, and the people surgery and the patient shows the very tight, and we check the FFR, the right coronary region. This patient was reduced the FFR. So we decide the primary purpose of this patient, the reduction of the perioperative risk. And so we put the biofreedom in. The biofreedom is, usually used for the a preoperative patient, and 1 month later we can do some major surgery. So this patient, we put the biofreedom and then simultaneous TAVR. And the Dr. Luca, and you comment about you do routine the coronary angio, even check the CTA, and that was your routine practice.
Sorry, please. No. What we do is just in one single shot, we do the CT scan. That CT scan is gated for the EKG. So in other words, we do everything in just one shot. I mean, and of course, it depends on the availability of the specific softwares, but also on the availability of the specific devices. I mean, if you don't have high-speed CT scan, it sometimes can be impossible, right? Impossible. But again, in terms of, let's say, a pre-workup, I mean, that would be great to have in just one shot all the information that you need. And I must say that I totally agree with you. I mean, depending on the urgency of the lung cancer surgery, of course, you need to adjust your strategy. But as far as I understand, this patient was not referred for, short of breath coming from the lungs or other problems, making it urgent. So I honestly believe that was the right approach. But again, this is something you must consider, because if the lung cancer is urgently treated, of course, you need to postpone the PCI or use, let's say, biofreedom, as you said before.
Can I just make one comment to both of you that are claiming that CTA before would be a useful approach? I think we have to be careful to make this a general statement. I think it depends very much on the experience. And I think if you try to do and decide to do a PCI in one session or postpone it, you really have to know in detail, not as open as this one. This is fairly straightforward, but imagine something on the left side that is a little bit more complex and complicated. You have to make a decision to do a procedure in one session or to postpone it. And I'm not sure whether a CTA can really answer all those questions related to this problem. Nevertheless, I accept, of course, this approach in order to save contrast.
Okay, great. And Dr. An and Jung-Min, and do you have any comment for this case?
No comment. No further comment.
Okay, got it. Okay, and we will from this and to the end and just the 7 or 6 minutes we will show our routine, the TAVR process, and then we will have another discussion time.
Procedure.
Yes.
Okay. Okay, over here. This is a ring torque, more hard tip over here. Okay, up there. This is the ring torque. Sometimes wiring was difficult and we should spend some time.
What kind of wire are you using to cross?
This is a ring torque wire. Yeah, the tip is much stiff wire.
Mm-hmm.
Okay.
Sometimes we change the AL1, AL2, the RCA, and the ring torque is much strong the wire.
Okay.
Yeah.
Looking at the LV, the pressure diagram and aorta diagram, you can see that there is a pressure gradient that is very severe.
Mm-hmm.
And then after insertion of a TAVR valve, we check it again, the LV and the aorta, the pressure diagram. Okay. The pre-dilation, and there is some different according to the position, the preference or in center, and some center, although the severe calcification, some center they does not.
Can I ask one question?
Okay, great.
So the diastolic pressure of the aorta is around 40 and slightly low. So how was his baseline AR?
It's a Dr. Go and Euihong. Can you comment on that? The status of AR.
Thank you for the question. The baseline echo showing just only the mild aortic regurgitation. And also on the angiogram, just only the mild AR.
And also about the expansion.
Okay, thank you.
Is not optimal.
Thank you.
In such a case, we do decide the predilation. The detailed criteria for predilation is amount of calcification more than 500 cubic millimeter. In such a case, we predilate, and less than for 500 cubic millimeter, we do not do the predilation, just only the direct stenting. This is our centered routine clinical practice.
Right.
Yes, our routine, on the basis of the calcium amount and the less than 500 cubic, and we don't do usually. We do direct the valve dilation, but calcium is much more than 500. We frequently do pre-dilation.
So why did you take the 500?
Yeah, there was the empirical threshold on the basis, and sometimes we do, and even the 700 we do, sometimes do without dilation, but it's on the basis of our empirical basis. Less than 500, we don't we don't feel the much resistance, but more than the 500, we sometimes feel the resistance past the valve to the calcified aortic valve.
Do that twice. And here is the target portion, but we unlock here and again lock and adjust the alignment again.
Okay, got it. Okay, and then we pass the aortic arch over here, and then make a band over here, and then the push smoothly, and then make a band, and the push and smoothly, and make a band, and the push and smoothly. Over here, we make sure the initial default coplanar view. Okay, over here, before insertion of the valve. 됐죠? 센터 맞추고. 자, 들어갈게요. 준비됐죠? Okay, got it. Okay, past over here. Okay. We usually try to the half and half over here. Okay, this is the most important test. 조금 더 진하게 AR이 생겼나? 테스트? 진하게 테스트? 딱이지? 오케이. 퓨터 좀 뺄게. 자, 다 여유 있죠? 테스트?
테스트.
오케이. 자, 준비됐다. 자, 페이싱 온. 자, 컨트라스트. 오케이. 인플레이트 쭉. 1, 2, 3, 4, 5. 페이싱 업. 디플릿. 오케이. 페이싱 오프. 오케이. got it. Here. Okay. Then remove slightly. Okay. Remove slightly. Esophageal echo, transthoracic echo. His view is excellent. And he is the better than usual day. And looking at the baseline, the transthoracic echo, and could you check it up the color? Okay, great. Minimal PVR.
In Asan Medical Center, more than 95% is now doing the MAC procedure without the general anesthesia.
And then over here, we're going to check it up. The angio, immediately the angio. Okay. 자, 됐죠? Okay, got it. We make sure the parallax was absent. Okay, over here, angio ready?
Ready.
Okay, push up. Okay, great. Okay, excellent. Today, and we do a successful PCI and the TAVR procedure. This patient would be eligible to receive the major OP in the 1 month, approximately 1 month later.
Yes.
At the time, we can quickly stop quickly stop the dual enterprise therapy. Just keep on aspirin alone. 자, 됐어요? 자, push.
Okay, we now checking the hemodynamics and pressure.
And very straightforward quick procedure was possible. Full support our heart team, and we have very nice cardiac surgeon. Also, this is a hybrid room, and the anesthesiologist doctor is fully.
This is hemodynamics.
Okay, looking at the simultaneously the flow diagram, and error index approximately 25, 30, and it's just the minimal more than 30, and the minimal the PVR. Okay, 다 쳤죠? And then the remove 입니다. Okay, push up. Great. Absolutely. How much PVR?
Less than mild.
0%. And then out of your view, this is very good to how much well circularly expanded in the valve. Okay, angio. Push up. Great. How much PVR?
No PVA.
Okay,
Zero.
so I'm gonna stop our first live case demonstration. This is a whole procedure, and at this moment I'm gonna share the expert opinion about our routine procedure of TAVR. And how do you think about the valve positioning? Is Eberhard, and how do you think about recently there was some the self-expandable valve and the cursive overlap view is even recommended for the balloon expandable type. Is shallow is recommended. How do you think? I'm gonna hear about the expert opinion, Eberhard and the Luca and okay.
Every location is very fine, and every procedure is very straightforward and nicely done. So I'd like to ask the panelists that is there anything we have to concern before operation? What is the safety zone before TAVR procedure and operation, and preoperative antiplatelet therapy? How should we prescribe? Is there any other consideration for this patient?
Any comments from?
Yeah.
Well, I guess again it was very nicely done, and I think in this case I must say it is really educational. Of course, you can discuss for a day about which specific device for this kind of patient. But I must say, once you have good femoral approaches, good femoral iliac arteries, and a good anatomy, I mean, with some calcification but not huge calcification, you don't have bicuspid anatomy. I mean, this is really, let's say, those cases where you can actually maximize the benefit of TAVR, because of course, regardless the specific device you're using, you can really achieve a very good result. And the only thing I can say, but I must confess, I'm a real fan, a big fan of cerebral protection. So the only thing we can discuss in this type of cases is to add, let's say, a further seatbelt in order to have the highest safety possible. But of course, I understand that there is a lack of evidence, but also there is a problem in terms of budget. But that's the only real comment I have. Everything else is absolutely on master level.
So my comment on that is, as you probably know, cerebral protection in Korea is not approved. It's not available. So it's not an option in Korea. The only thing that I would like to add, probably this is a straightforward case in terms of anatomy, calcifications. I think whatever device you're using, you will have a good result regardless. What I would have, in this particular case, I would have probably put the valve a little bit deeper. When you did the first shot with contrast, it looked like it was a little high. And since the S3 shortens from distal to proximal, it looks like maybe you could have done it a little bit lower, but that doesn't change anything. It's just an observation. Other than that, I think was a beautiful case and done very professionally, very straightforward.
Yeah, and the Yohei. Okay, go ahead. Yeah.
No, particularly the non-predilatation, is something that I really like.
Thank you. Yohei, how do you think is your routine valve position? Is nowadays some trend is shallow is better, and how do you think is nowadays?
Exactly. So, well, we have to think two things. Okay, one is to avoid new onset conduction disturbance, and another is the future coronary access or coexisting coronary artery disease. So in this specific case, I think Valsalva is large enough for the future coronary access. So even with Evolute series, I guess the coronary access after TAVI procedure would be feasible. Regarding the implantation depth, I guess we would have done almost the same. I think all of you know that there's a lucent line in the Sapien device where we can see it in the angio. And basically, it depends on the normal filling or underfilling, but we try to aim this lucent line in the annulus line so that it nicely shortens from the LV side, and then in most of the case, we can avoid new onset conduction disturbance.
Okay, great. And I'm gonna introduce the second operator and Professor Ho-Jin Kim, and he is only one cardiac surgeon have a TAVR proctoring certificate in our country, and he had a lot of experience, more than 200 and 300, and he do TAVR well. And the first case, cardiac surgeon Professor Kim will present another interesting case. So I'm gonna play the recorded another case, and Professor Ho-Jin Kim is the first operator, and during the live streaming and the middle time, I will have a first discussion time, and the end of the whole session, I will have a second discussion time. Okay, we're gonna start.
Okay, welcome to the TCT 2021 virtual live meeting, and we are very happy to show another very, the educative and very intuitive case. And I'm gonna start this live case demonstration with the introduction of our super team. And the left is a primary operator. He's Dr. Ho-Jin Kim, and he's cardiac surgeon. And only one cardiac surgeon in South Korea is got a proctoring for TAVR procedure. He had a lot of experience and 100 cases for TAVR procedure, and as a primary operator, and he has a lot of experience for TAVR procedure, and only one cardiac surgeon in our country. And the right is Dr. Euihong, and the senior fellow, and the right over there, and 조금 더 일로 들어와. Dr. Han-Bit Kim is our junior stat. Okay, we're gonna start the case presentation with Dr. Go.
Yes.
Okay.
This case is relatively young, 74 years old male with a worsening chest pain from the 2 months ago. Was referred to our hospital to check the evaluation for the chest pain. During the evaluation, echocardiogram showed severe degenerative AS with normal systolic function. And this patient got the CKD stage 3. And next, cardiovascular risk factors are diabetes and smoking, and he is a current smoker, and the age is 74 years old, and the SDS score is 1.8. And next, echo finding shows ejection fraction is 67%, and the Vmax elevated 4.6 millimeter per second, and the mean pressure gradient is 58 millimeter mercury. Aortic valve area is very severe, and 0.64. And next, this is a CT measurement of the annulus, and the annulus short diameter is 21 millimeter, long diameter is 26.6, and annulus area is 432 millimeter square, and perimeter is 74.5. And next, this is the size of sinus of Valsalva and the SC junction. What we focus on this slide is ratio between sinus of Valsalva and annulus. The ratio in sinus of Valsalva is 1.75, meaning that this patient have 1.75 larger than the annulus. And in ST junction, the ratio is 1.24, and relatively, this patient have a smaller ST junction. And next, this is a LVOT. LVOT doesn't have any calcium. And next, the quantification of the calcium is very important for the safety TAVR procedure, and this patient have a total amount of 417 cubic millimeter, and the average in our center of total calcium is 330. So this patient have a relatively large amount of calcification. And next, this is a longitudinal analysis of the distribution of calcification, and the calcification is just only located at the leaflet, not extended to the LVOT. And next, coronary height is more than 12. And next, trifera is relatively small. The right iliac artery is 5.1, the smaller than the manufacturer recommendation, but and accompanied by the calcium, but we experienced down to the 4.5 millimeter, so we can, I think we can close the valve. And next, this is the sizing for the Sapien 3. We have to do around the 110% area oversizing to the 115% oversizing, and then it's going to be the between the 23 millimeter valve and the 26 millimeter valve. And today we have chosen the 26 with a 2 cc underfill because of the calcification is not quite severe, so we can want to some space to oversize. So we decide to do the 26 millimeter with a 2 cc underfill, meaning that around the 112% oversizing.
So, and this patient is relatively, straightforward. Is a simple patient, and it's 74-year-old male. And looking at the STS score is just a 1.6, and so, and I think this is intermediate zone. The patient, a couple of weeks ago, and the new 2021 ACC AHA guideline was published since last 2013, and 8 years new version of the valve guideline that recommend more than 65-year-old the person recommended equal position of a SAVR and TAVR. You are the Hojin, you are cardiac surgeon. How do you think is new updated guideline?
Actually, this patient was referred by my senior colleagues from cardiac surgery, and just we felt that of course we can operate, but also we agree that TAVI is also good options, and I think this patient is a clear reflection of the new guidelines. Yeah.
Yeah. So 74 is okay, but how do you think 66?
I would still operate, but I will ask the patient. Now we have options. Now it's the TAVR, but I still feel I would just go for the surgery.
All right. I think it's a kind of our strong point as we can discuss with the cardiac surgeon in situ. Anyways, we've discussed a lot about the changes of guideline of HS guidelines in terms of age concerns. No matter what, risk score would be 65 years, maybe before and after. And as an internist side, we can do that, TAVR, right? Anyway, it kind of a same tissue valves, even if you try to, open heart surgery, and in terms of only, the concern was actually it was longevity concern, right? However, lots of things can do solved out. And, we have a very small different opinions. However, we agree that even in the low scores, STS scores, and even the younger ages, and TAVR would be good choice or standard for the future. Right? Okay. So you have already discussed about CT findings in detail, right? And as you just mentioned before, CT algorithm before the procedures, I think is very important issues to determine what size of device, right? And in fact, compared to the self-expanding stent, actually we measure and select the very discrete, precise, of devices, especially balloon expandable, stem itself. And so I think it's one of the most important, advantage is from the others. So personally, you and I, and based on the CT algorithm, the selection of exact, precise determinants, the total procedural success rate is more than almost 99%, right?
Definitely.
Right. I think so. So most important thing is what size the device would be. Main determinant still, I think the calcium amount, location, right, depending on how much is the area oversizing. So you would decide 10%?
Yeah, it's 10% and the 2 cc on the underside. So I think one of the discussion point, this patient is a moderate renal insufficiency, is a CKD. Although there has a CKD at creatinine was 1.5, and it's feasible to conduct a CT scan. Sometimes it's a very old patient. We cannot do the routine CT scan for size measuring. The reason why is CKD is creatinine more than 2.0, 2.5, and that was risk of renal replacement, the ESRD. At the time, it's a very not easy to determine the exact size. It's a couple of weeks ago, we experienced some catastrophic case. At the time, that patient's creatinine was 3.0. We cannot do CT scanning, so we just decide to sizing. It's a trans-esophageal echo sizing. Even though we use a 3D trans-esophageal, the sizing does not match. Patient has some root injury. So nowadays we do the specialist guided MRI measurement, and the TE is combine the two things and then decide. Looking at the MRI measurement and the trans-esophageal echo, there is some big size changes. One size change, and the MRI recommended 26, and the 3D TE recommended 29. There was big change. So there was some the last 10 case experience.
We need some
more data.
More data to compare with different sizing.
Okay. We will have a discussion time and this time, and we have two discussion points. One is sizing criteria is after release of the new HCCHA guideline. I'm wondering how the change of the aging criteria for TAVR procedure. And second is sometimes the patient is old age, it's creatinine more than 2.0, 2.5, but at the time we cannot do a routine, the CT angio at the time. Is how do you decide the valve sizing? There was a 2 point in the Eberhard. Could you comment on the sizing, the age threshold after release of new guideline?
Yeah, I've carefully listened to the discussion that you had in your cath lab. I'm actually quite surprised that Dr. S.J. Park is standing next to a cardiac surgeon doing a TAVR procedure. I think that's the first time in many, many, many years that I've seen this, but he at least indicated he has sometimes a little bit of a different opinion. But I guess he's getting a little bit older and a little bit more wise, a little bit more patient. So very good to see that. The other thing is, and I've listened, I know that in Asan, you are a fan of a rigid pre-planned procedure. That's what I'm used to when I worked at Asan or worked with you or proctored or assisted. Everything goes by the rule, and that's why I asked for the 500. Is there a reason other than 500? It's just something that you set up, and the same is for the age discussion. I think the age discussion is still open, and very honestly, I don't care what the guidelines say. Let's not forget, guidelines are recommendations. This is as important as they are. We still have to weigh advantages and disadvantages in terms of TAVR versus surgery. And we do have now other things to consider. Dr. Ohno said now we're focusing more on durability, coronary access, conduction disturbances, and things like that. Initially, that was different. So my point, the cutoff point is now very arbitrarily 75. Everything that's above 75 most likely tends to go to TAVR. Between 65 and 75, it's a heart team discussion. But if you don't have a heart team in Korea, then there's no heart team discussion. Then it's going to be what is the advantage for the patient and what's the disadvantage. And I think this is a very interesting and a good point that you're raising. I think he would be good for surgery. He would also be good for TAVR. He would be good for Sapien, for Evolute, for Actuate. I think, the calcification is mild to moderate. I wouldn't say it's severe. So it's a very nice case where you can discuss the age situation. And that's what you have done with Dr. S.J. So very, very interesting case. And I think as far as the sizing is concerned, the 26, you can notice the patient doesn't have much of sinuses. But the coronaries are high enough, so there's no worries about it. If the coronaries were in a critical distance, then I would probably use an Evolute. But I think here it is very reasonable to use your favorite valve in Asan, the S3.
Okay, great. And the Yohei and the Luca and how was some age threshold change in your heart team?
Yeah, so I think each country should have own threshold or strategy because the life expectancy is different among countries. And we have updated our national guideline. And basically, our approach is similar with Eberhard. Our cutoff is 75, similar to the European guidelines. because Japanese patients live longer. So we need to consider for a second valve, especially for younger patients. And as you may know, our patients has quite small sinus of Valsalva. So the second valve, TAV and TAV, could be problem for coronary access in some specific patients. So basically, we made the cutoff of 75.
75. How about the Luca Testa?
Well, I must say that we have a similar situation. I mean, I do not really believe in cutoffs, to be honest. I mean, it's clear that, of course, if you have, a patient in his 80s, no discussion. If you have a patient in his 60s, we have surgeons actually scratching their dresses if you even think about TAVR. And I believe that's reasonable. But when you are running the so-called zone, I mean, what's the difference between 74 or 76? Nothing. It depends on the patient. And I do believe that in particular, if you want to actually expand the indication to TAVR to younger patients, we must consider several issues you actually are already raised. And I'm talking about the coronary access, I'm talking about the durability, but also talking about the patient prosthesis mismatch. This is another thing because it is linked to the durability. I mean, the smaller, the worse. This is not just my idea. It's something that we know since a long time. So in other words, in particular in this relatively small anatomy, I totally agree about the, let's say, the choice of a balloon expandable. I totally agree. I mean, with larger anatomies, of course, you can think about self-expanding, you can think about supraannular, infraannular, you can do all this, let's say, all these thoughts. But for small anatomies and thinking about coronary access, balloon expandable are the right choice. I agree with this.
Okay, great. So, and the second question to the, Eberhard and the other panel about sometimes patient has creatinine more than 2.0 and 2.5 is not eligible for CTA in the CT. Yeah. And what is your recommendation? Is nowadays we have some painful experience on the basis of the 3D echocardiography measurement, and we have some root injury a couple of months ago, and now we are combining MRI and plus 3D echocardiography, and we usually more strictly follow MRI measurements, but it's not good as much as CT angio's. What is your recommendation? How do you thought about patient having renal insufficiency?
In my opinion, it's probably a matter of experience with 3D echo. If you have a reliable 3D echo or a reliable echo person with a lot of experience, then I would totally rely on 3D echo. We've done a comparative study between CT, MRI, and 3D echo, and they were very, very, very comparable. So depending on the patient situation, I would rely on 3D echo. I would not rely on 2D echo, to be honest, but on 3D echo, I would go. And if you do an MRI, that's also, of course, possible, but it's just another major examination and quite costly. So we would probably go for both MRI and 3D echo.
Okay, and any comment? And
I think the selection of self-expandable device would be good option.
Yeah,
because
right.
there is the size ambiguity in the sizing. So self-expandable device would be safer than the balloon expandable device.
Yeah, nice comment. Is how do you usually do in the Luca and the Yohei? Yeah.
What we usually do is we rely on a 3D echo.
3D
and
echo.
I must say, this is because, we started our TAVR program 15 years ago with the same guy doing the echo. Yeah. So as Eberhard pointed out before, it's a matter of experience. And to be honest, we tried with the MRI, we tried with the CT scan without contrast, we tried several ways. However, at the end of the day, when you have a very good and expert echo guy, that'll be very reliable. I'm not saying 100% because, of course, there is always a margin of error. That's for sure. However, it is reliable, but it depends on the experience you have.
Okay, great. And Yohei, how do you think?
Yeah, very important question. Well, we've been doing also with 3D echo, but the major deficit drawback is that it lacks information of calcification. So if the patient's creatinine level is below 3, I would say, we made a specific internal protocol using low dose contrast media, almost 30 milliliters of contrast, and our technicians would nicely perform a CT scan. And maybe it's feasible because our Japanese patient has relatively small body size, like BSA of 1.3 or something. We can have a very nice image with only low dose CT contrast. And if we give enough hydration to the patient, usually we don't get acute kidney injury with a low dose contrast.
Okay, good.
Can I ask one question?
Okay, it's a go. Dr. Go ahead.
How do you assess the access site without the contrast CT? How do you decide access site? It's a safe.
Yeah, I mean, what we usually do is we look at the calcification, and of course we select the site, the access with less calcification, and of course, if this is not enough, we basically do an angio, with 10 milliliters of contrast just before, in the same setting of the TAVR, just to confirm that we are proceeding in the right way. But if you look at the calcification only, you can have a lot of information anyway. Of course, you don't have enough information about the lumen, that's for sure. Anyway, if you our practice is to have radial access for the protection of the main axis. So from the radial, you can just inject 10 milliliters and you have all the information you need.
Thank you so much.
Yeah, we can also combine CT with that contrast. And as Luca mentioned, we take the information of calcification and together with MR angio without any contrast.
Great. So
yeah, but I think that the MRI is really cumbersome sometimes. I mean, they are older patients, and the acquisition of the MRI sometimes takes much time, a lot of time. So, I mean, I would be, let's say, careful before, suggesting that the MRI can be, standardized for all patients. I mean, of course, it gives you a lot of information, but again, if it takes 1 hour for the patient to stay flat on the table, that's not really feasible for all the patients.
Sure. Yeah, I fully agree. Okay.
Also, can I ask one question to the all panelists?
Okay, so Professor Kim, how about the ending of this procedure? We will have another discussion time. Okay, we remaining and just 4 minutes, and then we will have another discussion time. We will see how the cardiac surgeon do TAVR procedure.
That's more stiff. That can make a more straightforward direction. Good. Much nice direction. 조금 밀고, 그렇지. 딱딱하네, 그죠? 천천히 한번 해보세요.
This is our first choice is Teflon wire. If Teflon failed, then we select ring top. This is first select the Teflon wire.
Okay. That is some surgeon's scale. Okay, Floro. 조금 더 들어갑시다.
Very gentle maneuver.
Yeah.
Okay. Looking at the simultaneously pressure monitoring, we can find how much big the pressure difference, how much severe the aortic stenosis. Okay. Okay, got it. 보고 있어. 조금 더 살짝 조금 더. 칼슘이 좀 있죠? 400, 400.
Calcium was 400.
그렇지, 됐다. 조금 더. 됐어. 오케이, got it. 자, 여기서는 제가 볼게요. Is to try to pull back the sheath over here. 오케이. 다 준비됐죠? 테스트.
좀만
조금 더
더.
들어갈게. AR이 좀 생겼어. 오케이, we can find AR. 오케이, 자 테스트. 조금만 더 들어갈게요. 오케이, 혈압 괜찮지? 오케이. 자, 여기 정도. 테스트.
네, 테스트.
됐다. 자, 이제 조금만 더
들어갈게요.
오케이, 조금만 더. 됐다. 됐어, 이 정도. 됐어. 이 정도. 조금 더 나와.
조금만 더 빼겠습니다.
자, 이 정도. 됐다. 자, 테스트. 오케이, 좋아. 자,
좋습니다.
준비됐지? 저 밸브 껴도 상관없어. 자, 준비됐지?
자, 준비됐죠?
오케이.
페이싱 온.
컨트라스트. 자, 괜찮다.
오케이.
자, 올려.
인플레이.
쭉. 1, 2, 3, 4, 5. 디플레. 오케이. 페이싱 오프. 자, 오케이. 디플레. 자, 좀 센터에 놓고 너무 뷰.
This is a transthoracic echo. Yeah.
이거 에코를 보여줘야 되니까 에코를 좀 약간 너무 옆에 놓지 말고 중간으로는 못 놓나? 그렇지. 오케이, great. Over here. 오케이. Looking at the 지금 프러시 다 했어? The flow, the simultaneous press checking and the AR index and it seems like a 30, and there is just a minimal AR. And echocardiography, transthoracic echocardiography, no significant of PVR. Full shot. Okay, I think just a minimal AR. Okay, RA view. Okay, and you ready?
Full shot.
Okay, great. And just mild and minimal PVL, and the result was excellent. People, okay. Looking at the distribution is 8 to 2 and the 7 to 3, and the sizing is good, and this patient has a relatively narrow the sinus of Valsalva valve, looks like some pool peel over the sizing, and and we based on our CT algorithm, we 2cc the downsizing, and the result was excellent, and this is our typical example of.
Okay, so I'm gonna I'm gonna finish and this case, and this is the low risk representative case. So we will have a second discussion time, and with only one cardiac surgeon. Any question or any comment?
Actually, I think I'm the only cardiac surgeon in this room, and we all know that after new guideline came out, all the age criteria is going down. So I would be very happy to proceed with TAVR for patients with 75-year-old. But my question is, so when the patient is 75-year-old, and what kind of patient would you send the patient to the surgeons for surgical AVR?
That is
who do you ask?
Yeah.
I ask to all the panelists, because to all the interventional cardiologists.
Well, let me tell you and I totally agree with what Luca said, and Jonas said also, these age cutoffs are a problem for me also. And that's why you discuss these, and in our country anyway, for the majority of cases, when it is really a question of sending the patient to surgery or to TAVR, we discuss this together with the surgeon and find out the best option for him. And not always, is less invasive better. And at the end of the day, the cardiovascular surgeon, they're not our enemies, they are the partners. And, we have to look for what's best for the patient. Not regardless, but the cutoff of 75 is just very arbitrary. It is something that's been chosen. But as Luca said, what's the difference between 73 and 78? There's a biological age, there's a numerical age. All these things come together. For me personally, if I was 65, I would probably not go to TAVR at this point. I would probably ask the surgeon to put the valve in as big of a valve as he can. That I have to say has to change. It's not like what the usual approach was. We just put a valve in. Now the surgeons have to be the partner of the intervention cardiologist and the patient to do, if he has a small valve, not to put the small one in, but as big of a valve as he possibly can, even if he does a root enlargement. But that's something that's safe. And then for the second valve, I would use a TAVR. When you do a TAVR now with 65 or 68, depending on how you biologically feel, that can be, of course, always discussed. But I don't really think we have good and reliable data for the younger age. And with younger age, I mean below 70. So that's
if I can try to answer that interesting and provocative questions, I would say that I will probably send a patient to the surgeon every time the transfemoral approach is not possible. Because that's the real advantage of TAVR. I mean, every time you have to use alternative accesses, in particular without percutaneous approach, I would feel uncomfortable. That's a possible answer. Second, I would say I totally agree with Eberhard. I mean, we need to think about that the valve journey. I mean, if the patient is relatively young, you must understand that it is a possible second option. There is a possible second intervention. So in that case, the valve must be thought in order to make it possible. And I'm talking about the second intervention, the second operation. So if the surgeon is the one putting the first valve, the valve must be as large as possible, but also it should be a valve you can expand, you can fracture, maybe in the future. So in other words, we should stop thinking about this TAVR or SAVR like one-stop shop. This is not the case, in particular for young patients, because in 15 years, 10 years, there will be the case to do another approach, another operation. So we need to think about that, but not just us, the art team.
Great, wonderful. Yohei, how do you think?
I guess lifetime management is key word nowadays for applying these technologies to younger patients. As Eberhard and Luca already mentioned this thing. And if I answer that question, I would consider sending bad anatomy, especially bicuspid patient. Of course, bicuspid patients anatomy varies. So there are some anatomies that we can provide surgical AVR-like result, but on the other hand, very calcified raphe with bulky calcification in the leaflet, LVOT calcification with enlarged, dilated ascending aorta, I would definitely send to a cardiac surgeon. So I think it depends. If the TAVR procedure provides surgical AVR-like result, I would go for TAVR. But if not, if it finishes with suboptimal results, we can still offer surgery.
Okay, Jung-Min.
Can I ask a question to Yohei in Japan? I mean, the Japanese population are usually smaller people, and my understanding was that they are implanting smaller valves.
Exactly.
Has that changed now with the advent of TAVR in Japan?
Thank you very much. Very important question and a relevant question. So as you mentioned, especially for surgical heart valves, most of the patients had 21 or 19. This is the reality. But now we have obviously valve-in-valve option. So there's a mind change in the surgeons. So there's a data that they tend to implant, use bigger valves, but still, obviously the body size of the Japanese patient has not changed much. So still, I would not say majority, but still, let's say 30–40% of the patients are receiving 21–19 relatively small surgical valves.
Okay, Jung-Min, and then
regarding the renal protection, So the Hojin, Dr. Kim.
Yeah.
So what the risk of operation for the kidney function? This patient did not have kidney hemodialysis. So to prevent the further deterioration of kidney function, so can you consider the operation instead of TAVR?
Well, this patient's creatinine was the 1.8, if I remember right. So this patient didn't have a very severe chronic kidney disease. So I would not hesitate to operate on these patients, but some patient is a very severe chronic kidney disease, or patient is already on hemodialysis, and I would not operate if TAVR is an option. Definitely, I would discuss with in the heart team to proceed with the TAVR.
Great. Okay.
I know we're running out of time. Just one quick question to the surgeon. I mean, we know this patient might potentially be a kidney candidate, and we have a higher grade of calcifications in bioprosthetic valves. Would you still consider a bioprosthetic valve in this patient as the first option, or would you consider a mechanical valve?
Given that this patient is over 70s, I would still go for the bioprosthetic valve. And if even though I'm very concerned about early degenerations, then my colleague interventional cardiologist to do for TAVR for him.
Okay. And
okay, thank you.
Yeah. Okay. I think this session is very wonderful. I would like to sincerely ask sum up the Eberhard group, and you can sum up this session. And I'm gonna ask a closing remark for this session, please.
Thank you very much. It was a great honor to be a moderator in this session, together with Dr. Park from Asan and our international panelists. We had very interesting and instructive TAVR cases with various aspects of TAVR. We were able to have a wonderful cardiovascular surgeon who is of younger generation, so maybe a little bit more open to the TAVR questions. So thank you for having joined us and having done this case so successfully. We saw 2 Sapien cases, relatively straightforward, but as we all know, no case is always straightforward. There are always issues that can happen very suddenly. And being at Asan Medical Center, we know it's one of the most experienced centers of TAVR in the world. I would like to thank you, Dr. Park. I would like to thank my good friends in California, Japan, and Italy to have joined us and discussed this session. I hope this will be an instructive and enjoyable session to TCTAP virtual in late April. Thank you very much.
Thank you. Great. Appreciate. Thank you.
Thank you.
Thank you, Eberhard, and thank you, Yohei.
Thank you.
Yeah.
Thank you.
Bye-bye.
Thank you.
Thank you, Luca.
Bye-bye.